So this is the part of
Sir, Archana Bhalia.
this is the part of chapter 4 in your clinical research and pharmacovigilance subject. Last class you have seen that seminar on the history, the types of pharmacovigilance, and their implementation in India and internationally. And today we'll see these chapters. Very importantly, how to establish a PV center. PV center is nothing but pharmacovigilance center in hospitals. You have seen there is a program earlier called as National Pharmacovigilance Program, and now it is called as PVPI, that is Pharmacovigilance Program of India. This PVPI program in India now becoming very successful because they have different ADR monitoring center, that is known as AMCs, at different regions in India. If you see in Karnataka itself, the AMC centers are like the Nimans, the Rajiv Gandhi, and Indira Gandhi hospitals, JSS Mysore, okay, the MS Ramaya. These are all the few AMC centers in Karnataka. So like this, there are different AMC centers where they collect the ADRs and send to central PVPI centers. So in this aspect, most of the big hospitals, they are offering us the AMC center. Even in our Baptist hospital, we are trying, we have written a letter to establish a PV center in the Baptist hospital. And this becomes a very important thing, like because the hospitals has patients uh, where they use the drugs. So obviously, when they use the drugs, the adverse drug reactions are quite oftenly can occur. So there, even from the patients, not only inpatients, from outpatients also, patients may come there for any reactions. We should have a very systematic system to capture all this information and share with the central system. So central system, it will again share all the areas to the Uppsala Monitoring Center, that is UMC center in Sweden. So globally maintained by the WHO. So the WHO will have all the reactions due to the drugs in all the countries. Okay, so they take a lot of decisions. We have seen in the last class, like the drug may withdrawn from the market itself if it is very severe conditions. And you can see this the establishing of PV centers in the hospitals. It's a, as you know, like pharmacovigilance center means what definition is an expertise, the art and science of monitoring and analyzing of drug and drug reactions. So when you set up this any pharmacovigilance center, it should get approved from authority, because we have pharmacovigilance centers. Even even the drugs control department in Karnataka, they have a pharmacovigilance center. Okay, so they all should get approved from the regulatory authorities. So regulatory authority in sense here is the PVPI only. So they are called the regulatory authorities, and even they shares all this information with the DCGI, Drugs Control General of India. And also very importantly, in India, we have the another board like CDSCO, Central Drug, this one for regulation of the drug, CDSCO. So that along with the DCGI are responsible for any kind of regulatory activities in India. So any functions within the regulatory authority, hospital, academic institution, or also can have independent facilities, like a trust or a foundation can have a pharmacovigilance centers apart from the hospitals. So this is how the pharmacovigilance framework totally looks like. We need people, so resources, call it as resource persons, and there are few functions that goes on here. And also we need a lot of structural, that is the basic facilities to run kind of this, the vigilance activities. So if you see that the first part, the functions is reporting. Uh, Reporting in sense like patient took the drug and had some uh, the adverse drug reactions. So when it is patient has the adverse drug reaction, who will report? It has to get identified and report. So that's what the main first function is. That is detection and generation. That is report side effect and suspected adverse drug reactions. So here in this function, the people involved here are anyone, doctors, pharmacists, nurses, or any other healthcare workers. That is CW is healthcare workers, or also consumers. The patient itself can complain all those things. And also the manufacturers, you can see the structures who are responsible for here is now the vigilance, pharmacovigilance, they have done a very strict actions like all the manufacturing unit also should have the pharmacovigilance center. So they made mandatory. If they don't have pharmacovigilance centers, they cannot run a pharmaceutical company because the products they are marketed, the particular company will be responsible for collecting the adverse reactions related to that product. So that's they're also primary. That is not they just cannot only sell and keep quiet. Okay, after selling also what any adverse reactions or any issues are happening, they should report back. So that's how it has to be made mandatory for all the manufacturers also. And next, what happens to this data collected, detected is data collection, that is evaluation. They do the evaluation, they collect the data, conduct initial analysis, and also they do the causality analysis. Causality is nothing but whether there is related to the drug or not related to the drug. We call it as relationship, causal relationship, and also the risk determination. So here they will establish a causality, determine if any epidemiologic studies are required, if anything that found. Okay, that's they will do an establishment of any association of the drug to the event. So here the people involved here are known as evaluators, where again medical specialists, doctors are involved here, the clinical people, pharmacologist, clinical pharmacologist, where the areas are there, the pharmacist, and also epidemiologist. So this is the part where you also get a lot of in the industry sides we have pharmacovigilance jobs. So many of the pharma graduates they go to this kind of job only. And same way the structure wise they have pharmacovigilance center to make these functions, and also drugs and therapeutics committee. So all the hospital they have drug and therapeutics committee, or it also call it as pharmacy and therapeutic committee, PTC or PT. Even in our hospitals there is there they will take a lot of decision on which drug to include in the hospital to use or not, all those things, and they also see the areas. And also safety advisory committees also, there are different committees involved in this. And you can see the next function is decision making and appropriate action. This is so okay, there are some areas and everything is there, reporting, analyzing and everything and sending. So what happens to that area? So when, as I told, there will be a signal detection, anything that is unusual things that's happening, they will see that and take a decision. So in the decision can be package insert amendments. Package insert nothing but patient information leaflets. That's every medicine will have a slip most of the time, even the syrups or any kind of things. And in that slips they will be written, given all the directions. So that changes can occur, warnings or any changes, scheduling changes, risk management or market withdrawal. Drug only can be withdrawn from the market, or also the product recall. So these are the things which the decision making and appropriate actions can be done. But here you can see that the common man people or any other healthcare professionals or pharmacists are not involved because it will not be in their hands. But if you see here the structures wise, the regulatory authority. So they are the concerned people who take the actions on it. There are also industries, health services, professional groups, advisory committees, media. So these are all the structurally they make these decisions finally. And lastly, you can see this the whole activity. The aim is primary goal is to prevent the medicine related problems and reduce the morbidity and mortality due to the drugs. Okay, are you following?
Yes, sir.
So why the need of pharmacovigilance? We have seen yesterday also too many things, and there are too many drugs and irrational combination, aggressive marketing. So that's what increasing availability of drugs makes, and also irrational practice are given because treatment without provisional diagnosis, wrong choice, and incorrect dose of drug, lack of documentation, and it will result in medical errors, lead to adverse drug events and not ADRs. So there is quite difference between adverse drug events and adverse drug reaction. Adverse drug events is nothing but if there is no causal relationship with the drug. Adverse drug reaction means there is a causal relationship. I can give you an example. Like if the patient is taking any drug and he is driving a vehicle, a two-wheeler, you can just say, and he met with an accident. He fell down from the two-wheeler. Okay, so this becomes an adverse drug event because the
Due
patient,
to
pardon, or if a person is who is taking some drugs, is slipped from steps. Okay, so that is also an adverse drug event. So here the reason can be many, not only because of drug, but drug also can contribute. One such example, if the patient is taking some pregabalins or any kind of histamines, antihistamines, sedative antihistamines, where he may get dizziness, reduced consciousness, all those things. Because of that, also the person can meet with an accident. He may not see, blurring of vision can occur. That's why the incident can occur, or there is all other possibility also. If someone has come suddenly into the road, or some other person came and hit the vehicle, or in the skipping in the steps wise because there could be some dampness, some wet, or even talking to some other people person and walking. So this also could be other reasons. So that's why adverse drug event means there is not actual and correlations or relationship causal relationship with the drug, but drug also can be little bit contributed to that but not fully. So then we call it as adverse drug event. But if we say adverse drug reactions, it's a, it's a 100% sure that drug only has caused. Example, there is nothing problem with subcutaneous cutaneous reactions, but after taking the drug within few 2 hours, you develop a rashes. So here we can directly we can say that after taking the drug definitely, and you are not exposed to any other things, but react some cutaneous rashes occurs. So here the correlationship of the drug to the reaction is very clear. So during that time we call it as adverse drug reactions. So it's a very important concept. So adverse drug event, all adverse drug reactions can be adverse drug event, but all adverse drug event cannot be adverse drug reactions. So that's the major difference between these two terminologies. And also there is lack of culture for rational practice and following protocols and all those things. The scope again, there is a lot of scope for pharmacovigilance center. They communicate about risk and benefit to patients, prescriber, and public. And also we have to take the active surveillance. That's the thing which we call it as active surveillance. Is look for uh, any adverse reaction. It's not that you just keep quiet and only some reactions occurs if they report. That becomes a passive surveillance. After occurrence of areas, okay, you take that this. But active surveillance is that before occurring of any areas, we have to identify the patients who can probably um, can need to get this ADRs and all those things. So, and we have to go and look probably. Like example, like I can give an example. Like patients are taking like some 8 to 10 drugs or more than 5 to 6 drugs. So definitely there could be lot of risk in those patients, or patients which have been having renal failure, kidney failure, very elderly patients, they also have a chance. So in this you have to look for any adverse drug reactions. That's what we call it as active surveillance. So that system will be available if you have pharmacovigilance center. And also you can train healthcare professions on ADR reporting, because many physicians and nurses also they will not report properly ADRs. We have to make that one major because we have been involved in this ADR reporting since a very long time. The doctors and nurses they feel like, okay, if some reactions occurs, then it becomes their responsibility. They may sue in the court and all those things. The misconceptions are there, but that is not the reality, because any drugs, if you are given a right dose, a right frequency, and everything is appropriate, and still it causes some reactions in the body. So the healthcare professional's role will not be nothing, because it's a innate property of the drug which may cause that reactions. So will not be any legal consequences. So that's what we have to train them. And also you have to communicate drug related information to any regulatory authority. So the center will do that. Plus a public awareness, it has to be brought how to use the drug and what all should be taught to the public. That's a very important thing. And there's no like who can report adverse drug reaction. Anyone, whether you friend to someone, friend can report, or even if you're not aware of that person, still you observe thing you can report. So any healthcare professionals, doctor, including dentists, nurses, pharmacists can include, or any consumer again you say like anyone in this, your friends, in the family members, or anyone, you any one person can report behalf of others. Okay, but you should have a consent. You should be knowing that person at least by the identification, or even the patient can give. And marketing authorization holder, is nothing but here the industry, the marketing, the the product marketed, no, the company is the marketing authorization. We call it as MAH also. Then how to report these adverse drug reactions? So as I know, like there is a CDSCO forms available online. There are mobile app also to report the adverse drug reactions. The very simple, they ask the thing. Then very importantly here, you should not do the patient identification. Patient identification in sense, you can give only the age of the person and gender of a person, but you should never include the patient name, patient address, patient email, and patient telephone. Unless you are the reporter, if on behalf of others, the reporters can details can be given, but not the patient details, address, telephone, because that is what we call it as we have to maintain the patient confidentiality. Okay, anonymous, we have to do the things. Should patient identity should never be included anywhere. So even the higher authorities, regulatory authority will not be knowing who is that patient. So that's how the medical ethics, it's a part of the ethical issue. So there is a manual submission forms and also online submission, which is there. And it can be sent to CDSCO, or as I told, DC, Director General of Health Sciences, and Ministry of Health and Family Welfare. So this is the way to reporting. So when you submitted the adverse drug reactions, what happened to submitted informations? So as I told, like there is a peripheral pharmacovigilance center, regional pharmacovigilance center, zonal, and also global pharmacovigilance, Uppsala monitoring center. That's how it goes. So usually in peripheral pharmacovigilance, they collect the information, check for 4 primary information. You can see that what is the 4 primary information is like for any adverse drug reactions, there should be a patient. Okay, patient should exist. Okay, because patient should consume the drug, only then it can. It cannot before consumption nothing will happen. Even if something happens, that will not taken as adverse reaction. So there should be an identifiable patient, there should be a drug name or product name, whatever it is there, and there should be an adverse drug reaction. And fourth one is there should be an the uh, reporter, that is known as identifiable reporter. So the reporter identifications can be given here, but the patient's identification should never be given. So that's what we call it as maintaining confidentiality. So these four primary information should be there in any reports, and these reports will be sent to regional pharmacovigilance centers where they do the causality analysis. Also zonal pharmacovigilance center where they do the statistical analysis, and also uh, with the global pharmacovigilance center, that is Uppsala monitoring center. So it's need to provide many emerging centers with more information, especially the materials and the resources should be there in any pharmacovigilance center. So here there are a lot of procedures like how to operate a pharmacovigilance center, and what kind of support is needed, and where to find adequate literature source. You have to check any reactions that occurs. You cannot blindly say that okay, this is, you can take it. You have to search in the literature, see that any reported reactions are there, whether these reactions will cause or not, and all those things. And also you see the relationship to the with the drug information centers and poison information centers. And also what kind of assistance can be expected. So once after the ADR is identified, you should be able to give the treatment for the type ADRs. So how to manage it, whether we have to withdraw the drug or without withdrawing drug, anything has to be given. Usually they give a steroid or antihistamines for reducing of any sensitivity reactions. So the specific any antidotes are available. These things you have to share with the thing. And for pharmacovigilance center, as like financial requirements is much a must. Involvement without of money, nothing can be done. So now, like same any other thing, pharmacovigilance centers also need financial requirement. Same for the infrastructure, because you need a place for setting up the pharmacovigilance center. You need an place, you need computer systems, you need all the required infrastructures for the printers and all those things, internet. These are the few things, and human resources as well to work, collect the information, analysis, and this. And for the communications, as I told, internet or telephone, such kind of things should be there. And operational expenses should be there daily operations, like especially for printing, taking printing, you need the papers and such kind of things. Okay, the operation expenses. Same way, the pharmacovigilance centers need all these kind of the support. And for any kind of things, there is a capacity building model is developed earlier. So you can see that the structure, it's a pyramid type of structures, where if you say that there is a structure, systems and roles at the bottom and the tools at the top, and in between you can find the skills, staff and infrastructure. So if for any kind of the systems to be working, you can see that the structure, systems and roles will be an effective use of this by the staff and infrastructure. The staff infrastructure will use, okay, structure, systems and roles. So here in the structure, systems and the roles, you should have a policy, pharmacovigilance policy, legal provisions, guidelines, SOPs, like protocols, drug safety advisory committees, and there is pharmacovigilance and drug information center also. Many times pharmacovigilance center is also will be drug information center, which you can totally say that how many any information regarding the drug is given, can be given. Same clear organogram will be there, who is reporting to whom, all those things, and dedicated budget, coordination between stakeholders, and drugs and therapeutic committees for facility level pharmacovigilance, timely and effective information. All these things, information will be there. So, and also next is the staff and the infrastructure. So the staff and infrastructure is again, it enables to effective use of skills. Okay, so that's how it goes. So here it should be separate staff for pharmacovigilance, communication technologies, and core reference materials, reporting and monitoring system, and adequate facility infrastructure also. The next is the skills. Again, the skills also enables effective use of the tools here, and the presence of pre-service and in-service trainings on pharmacovigilance. They should have skills to do any kind of work. Okay, the acquired knowledge. So public education has to be given, active surveillance skills. All these things should be. So person should be able to say that okay, this person may get ADRs, and if he gets ADRs, how to identify, how to collect it, and all those things. And lastly, you can see the tip. At the tip, it is the tools. So tools is nothing but the systems which usually used for the like pharmacovigilance reporting form. So there is a form which you use to collect the report. So that's the tools. Then how to know the filling this tools is you should have skills, and who has to do it is there the staff and infrastructure. It goes like this. And also databases should be there, training manual, assessment tools, decision support tools. As you know, like causality assessment tools, we have so many NARINJOs, WHO, Larson Karinga scale. So there are so many things. Also severity scales we have. We have scales for predictability, preventability. So there are a lot of tools that we use to assess the adverse drug reactions. And the infrastructure location is also very important. Which part in the hospital they should have. So in the PV centers in the hospitals is again many times they keep it in somewhere which is not much accessible area. But as per this one, there should be a good accessible area. It should be anywhere in the ground floor, near the pharmacy, or near the any kind of the boardrooms or anything where people can go and discuss with them. Okay, so that's the main important. The location is very important there. Also, equipment should be a lot of internet. Should have not only internet, equipped with a lot of books, literatures, journals should be kept. So anywhere they ask for any kind of literature evidence, you should be able to show the articles, the evidence-based proof, and also database. So database also it is which is there. Like CDSCO database, they have even the Vigibase. There is there from the Europe. They use for the collecting the areas. Same way collecting the areas, there are different databases should be there. Communication, as I told, multi-line telephone should be there for connecting the thing. The internet should be there, fax, and this all now becomes a very basic need for communication with the regulatory authority or with the other departments, and also with the healthcare professionals. This becomes a very important the requirements. The operation expenses also can occur, so that has to be taken care, like electricity, as you know, like maintenance and miscellaneous day to day, the toll paper, all those things. So these are all the few things that you have to consider for the when your pharmacovigilance center is being operations. And the human resource system, we are saying that overall required for setting up a pharmacovigilance center, the hospital. So physician can be there one, so, and also number of designations required only one, and part time is required, not full time, not required there. And you can see that the salary again changes so much of different things. So as per the economic wise, that it's given as in like this salary as a whole, salary as per unit as a part time. So only when and required the physicians can come. but no need to be physician as full time. And also the data processor can be there. If two full time can be should be there for processing. Again, the salaries you can see there. And also customer care executive for any people to interact with the people and all those things to full time. And the quality assurance person has to be there. So any process that's going there, QA should be there. So QA and QC, quality control. So quality control is not required here much because quality assurance. So you know that what is the difference between quality control and quality assurance? Quality control is ensures that everything is fine before the product is made. Okay, so what are the different process procedures in this one, what's happening, so all those things. Quality assurance is nothing but once after the product is done, check whether the specification, whether the product meets the specifications or not. And same way like this for any kind of the areas filling forms and all those things, they have to check it after filling the forms. The legal person also should be there, could be part time. Again, as I told, like if some given the drug and occurs some this one, but there will be not much legal implications here if the drug is given correctly. But the persons, people, patients can uh, unnecessarily can put the all the these issues on the healthcare professionals. Is like this physician gave me this drug and I had these reactions, so I want to sue him in the court. So that's how few times the patients can react to any kind of reactions. And also so during that time the legal persons also should be given the their views and how to deal with the case. The coder also, the medical coding is another thing because the terminologies that reported by some patients are something like very vague. So the medical coders, they are there like ICD or metra coding. So there are softwares that we use coding certain medical terminology. And also IT professionals, one full time because systems, internet, all there. There should be an office boy also. And there is also a budget which is specified in the thing. So we have a software, as I told, Vigiflow. This is for the European system that is more commonly used. So it will be, that's the software they use, and you can see the cost of capital cost and also total cost. And human resources definitely, and computer should be there, office, printer, fax, photocopier, furniture and fixture, telephone, internet and operation expense. The capital cost here, the cost what we stated here could change. Okay, so it can vary. It can vary in the different cities, type of the hospital, and who's could change this the capital cost and the total cost. So, but only you can see the uh, requirement. Okay, the capital cost can be higher than this in big cities or big hospitals. Also can lower than this in small hospitals or in the small cities. So this is how mainly if we see that the 60% of the budget can go will go to human resources only, paying the salary, and followed by the infrastructure and uh, the operation expenses and communications is very less. And there is an Vigi-based online, so it's a web-based software which mainly seen in the Pharmacovigilance Center. So they give the electronic transmission of refits within a country. So all over the countries, the reports will go there. So it will make communication between the prescribers and also pharmacovigilance centers. So that's how the Uppsala Monitoring Center also it does. It collects all the information all over the world and make it. And they also give a lot of alerts. We call it as drug safety alerts. Okay, so they may give that, okay, this drug is causing these reactions, please be careful. Or when this drug is prescribed, be careful for these reactions. Such kinds of drug alerts can be given because of these things. And in the hospital and the pharmacovigilance center, when they establish there,